Hey everyone, welcome to Al's OT Review. This is video module number 1. Check out my other videos if you get a chance. The topics range from budgeting for OTs and OT students to how to prepare for a job interview. Since you're here to study for the OT exam, you might want to check out my video on study skills. I'll drop a link for that in the comment section below. Alright, that's all. Let's get started. In this module, we will be looking at cautions and precautions. We're going to look at 3 categories. One is the physical components related to cautions and precautions. The other category is mental health, and the last category is miscellaneous. Let's start with the outline of what we're going to chat about. For medical or physical cautions and precautions, we're going to chat about definitions, clinical syndromes, and corresponding levels of precautions from evidence-based meta-reviews, some tricky practical situations such as individuals with MRSA and HIV. We're going to look at diabetes, edema, and lymphedema. We're going to look at modalities like cryotherapy, ultrasound, TENS machines, and moist heat. We're going to review cardiac rehab precautions and precautions, autonomic dysreflexia, also known as hyperreflexia. Then we're going to look at Buerger's disease, auras and seizures, then hip and sternal precautions, and implications for OT practice. For mental health, we're going to look at the patient journey and considerations, hallucinations, MAOIs, and the serotonin syndrome. Finally, for miscellaneous, we're going to chat about abuse and lines of reporting, and dementia and sexual activity. We're going to start with the medical and physical conditions associated with cautions and precautions. Let's jump in. This is a really good definition from the Provincial Infectious Diseases Advisory Committee. Routine practices are based on the premise that all clients, patients, residents are potentially infectious even when asymptomatic, and that the same safe standards of practice should be used routinely with all clients, patients, residents to prevent exposure to blood, body fluids, secretions, excretions, mucous membranes, non-intact skin, or soiled items, and to prevent the spread of microorganisms. As an OT, you're the healthcare provider, so you must assess the risk. You also have to identify strategies that will decrease exposure risk and prevent the transmission of microorganisms. We're going to go over these in the next few slides. First, what are the elements of routine practice? Conduct a risk assessment. This includes the patient condition, risk factors, and environment. Complete hand hygiene. This is part of routine practice. Control of the environment. Think isolation rooms, sanitization of the environment or medical equipment, like cleaning TheraBand or exercise equipment. Administrative controls, including policies and procedures. Perhaps you've seen this on your rotations where there's a flu outbreak and they have infection or prevention standards in place. As well, sufficient, easily accessible, and appropriate PPE to prevent healthcare provider contact with blood, body fluids, secretions, excretions, non-intact skin, or mucous membranes. Be familiar with how to don and doff your PPE, including gown, gloves, facial protection, N95 respirators. If you want to go over the steps for donning and doffing the PPE, I'll drop a link for that in my handouts available on my website. You can download my handouts for free. While these definitions, contact, droplet, and airborne precautions, even the routine practices we just went over, might be common sense to you, the definition matters. So let's quickly look at these, and I'll give you some examples. Contact precautions involve gloves and a gown if skin or clothing will come into direct contact with the client, patient, resident, or his and her environment. Droplet precautions involve everything above and add facial protection, mask, eye protection. For example, the flu would be indicative of droplet precautions. Airborne precautions involve yet another layer, an airborne infection isolation room involving negative air pressure and your fit-tested N95 respirator. An example of syndromes which require airborne precautions include chickenpox or active TB. Lastly, this arrow indicates severity. It's funny because I keep a beard most of the time, so when I go for N95 mask fitting, I have to shave my beard. Which makes me wonder, if there's an outbreak on site and I need my mask, am I supposed to shave right away? Moving right along, I'm going to put up this chart. It's for clinical syndromes or conditions and their corresponding level of precautions. Take some time to study this chart. The chart is also embedded in the handout available for download on my website. I'm going to move to the next slide now. There's a couple I'd like for us to go over because they're tricky. The questions we're going to ask ourselves will help in the decision-making process. MRSA. MRSA is a mutated type of Staph aureus which is resistant to common antibiotics. MRSA is spread by skin-to-skin contact. Sharing personal items also increases the risk of transmission, which could affect group therapy or rehab programs. So what are you supposed to do? Follow hand hygiene practices. If the wounds are draining and site policy recommends droplet precautions, wear personal protective equipment. This includes your gloves, your gown, and a mask to limit contact exposure. I don't have a perfect algorithm regarding OT implications, but rather consider these questions to guide your clinical expertise. Firstly, what is the patient's cognitive status? Is the patient immunocompromised? Is the MRSA localized or systemic? Is it present in the wound or wounds? If so, is the drainage contained with dressing or is it leaking? Can the patient tolerate the dressings? OT implications. The patient may be able to participate in group therapy depending on site policy. Are there resources for the client to be seen in his or her room for rehab or exercises? Let's talk about HIV and AIDS. HIV is a virus that attacks your immune system. But having HIV does not mean that you have AIDS. HIV is the retrovirus that causes AIDS. If HIV is not treated and progresses to AIDS, your symptoms get worse and your body is less and less able to fight infections. The mode of transmission for HIV is certain body fluids. In the United States, HIV is spread mainly by having unprotected sex or sharing injection drug equipment, such as needles. What are the OT implications for HIV and AIDS? Medication management, as patients with HIV receive numerous medications, frequently called an anti-HIV cocktail. So you want to ensure that they have the right system in place for taking their medications as scheduled. Patient education about the use of illegal drugs, education about limiting alcohol, smoking cessation, healthy diet, including storing food safely to reduce the risk of a foodborne illness, as people with HIV are more likely to get foodborne diseases. As well, exercise, emotion, and social support groups, as HIV is an invisible disease, and preparing for an advanced care plan. When working with someone who has HIV, you have to follow routine precautions and you must avoid contact with blood and body fluids. So let's take a step back for a moment. There's been a lot of technical information thrown at you. What are you supposed to do with it? How does this affect OT practice? Let's look into this. Use disposable patient equipment when possible. If equipment cannot be dedicated for single patient use, clean and disinfect it between patients. This applies to all equipment. I'm thinking slings, blood pressure cuffs, wheelchairs, walkers, crutches, TheraBand. The list goes on. Do not share items which cannot be disinfected. I remember seeing a video for the butterfly model for patients in the dementia safe living units. They were using sensory toys. It was a fluffy teddy bear, which looks comforting, but it is a germ breeding ground. This is definitely something to consider for sensory or adaptive items we're frequently providing to clients. Patients should leave the room or bed space for essential purposes only. Before they leave, ensure they've completed hand hygiene. Wounds or drainage is contained, and they're wearing a mask. If a patient has been placed on precautions, consider if there are resources to see the patient for individual in-room therapy. Diabetes. Diabetes is characterized by hyperglycemia, high blood glucose. It's a chronic disease with a progressive course, and it increases the risk for kidney disease, vision loss, heart disease, stroke, and neuropathy. There are 3 main types of diabetes. In type 1 diabetes, the onset is rapid and acute. Here, there is insulin deficiency, meaning insulin is no longer produced by the pancreas. In type 2 diabetes, the onset is gradual. Some foreshadowing here for the OT implications. There's a strong lifestyle component associated with type 2 diabetes. Type 2 diabetes is characterized by insulin resistance. Insulin is produced, but no longer able to perform its function. It's not getting absorbed. There's also gestational diabetes, relative deficiency of insulin during pregnancy, when insulin resistance is higher. There are other types of diabetes, but I'm not going to delve into the details here. Instead, we're going to chat about OT implications. OT focuses on lifestyle modification, health promotion, including regular eye, foot, and dental exams, remediation of physical and visual impairments, and maximizing self-care independence. As OTs, we want to mitigate complications that interfere with the ability to complete self-care activities. Let's delve into some details. OT role. Promote healthy food choices such as safe adaptations in cooking, planning, and meal prep. Also, integrating exercise and physical activity into a daily routine. Organizing and tracking medications. Instruction in the use of low vision and non-visual devices, like monitoring blood glucose, keeping a log, taking blood pressure, conducting low-cost self-foot care assessments, and incorporating protective techniques and compensating for peripheral sensory loss, which affects temperature detection, the risk for pressure sores, and associated offloading. This includes wearing appropriate footwear and clothing, and lastly, coping skills and access to support services. So diabetes here is a good segue into edema and lymphedema. Clinically, we say that if edema is left untreated, it becomes lymphedema. In reality, it's a little more nuanced than that, but for the sake of our purposes, this will work. We're going to go over edema and lymphedema, and then tie it back with implications on OT practice. Edema is an accumulation of fluid in the interstitial space, which leads to an abnormal expansion in interstitial fluid volume. It can be systemic or localized. If it's localized, a trigger for localized edema would be acute injury, for example, a fracture. Another condition you're likely to come across is complex regional pain syndrome. When it's systemic, the typical triggers are venous insufficiency, renal disease, cardiac disease, obstructive sleep apnea. These are systemic concerns. This means that if it shows up in the lower extremity, in theory, it should show up in both legs. So if you see edema on one side, and this is important, your critical thinking cap should be on, and you should be looking to rule out a DVT, also known as a deep vein thrombosis. The symptoms of a DVT include one or unilateral sided pitting edema. It's painful. Often the patient will report a sharp pain, redness, there's an acute onset, and the Homan sign test, which is with the knee in extension, with one hand you dorsiflex the foot, and the other hand you squeeze the calf. A positive sign is noted if it's painful for the patient. OT implications for DVT. Do not compress, as we do not want to dislodge the occlusion. Report your findings urgently to the medical team. Now let's talk about lymphedema. There are a few different types of lymphedema. A brief note on the pathophysiology of lymphedema. If there's lots of protein and fluid in the lymphatic system, they begin to accumulate in the interstitial spaces. The material trapped in the interstitial spaces that causes lymphedema has a higher concentration of protein. So there is primary, secondary, and congenital lymphedema. In primary lymphedema, it's not attributable to any specific medical condition. It also affects the lower extremities 3 times more often than the upper extremities, and it's not a progressive disease. Secondary lymphedema. This is more common, and it's caused by an obstruction or trauma to the lymphatic system that interferes with lymphatic flow. The condition is most commonly caused by injury or removal of regional lymph nodes during surgery or radiation therapy, infection, or due to tumor growth. Congenital lymphedema is typically characterized by absence or abnormality of the lymphatic tissue. We're going to spend a few moments looking at the treatment implications and implications for OT practice. Lifestyle plays a role, and patients should be encouraged to consume a healthy diet, maintain a normal body weight, and participate in regular exercise. Patients with lymphedema must be cautious to avoid infection. Elevate the affected arm or leg above your heart. This is assuming there's no cardiac or circulatory failure. More on this later. Avoid having blood pressure drawn or injections given at that localized site, and avoid taking blood pressures at the localized site. To decrease the risk of ulceration, sitting on pressure offloading surfaces, don't sit for more than 30 minutes, and avoid creating pressure hotspots, like crossing your legs for a long period of time. Avoid tight clothing and jewelry. Do not use heat or ice modalities due to the limited sensation due to the buildup of fluid. Avoid using that affected limb to check the temperature of water. Make sure the patient is wearing good footwear and to encourage pressure redistribution and reduce shear. Apply moisturizer often and emphasize the importance of regular nail care. Compression bandaging. So where I work, we regularly perform lower leg assessments and we do a full medication review, clinical presentation assessment, and we check the patient's blood pressures using a Doppler. We often wrap patients with lymphedema using compression bandaging, which is slightly elastic. Compression bandage therapy for lymphedema requires the application of more pressure than compression bandage for venous disease. About 30 to 40 milligrams of mercury for basic edema versus about 50 to 60 milligrams of mercury for lymphedema. So what are some of the considerations for compression therapy? Arterial disease is a contraindication for the use of compression bandages or garments. Caution should also be used in patients with hypertension, paralysis or poor sensation, diabetes, asthma, and heart failure. Stay away from edema reduction if there is an infection, skin grafts or wounds, or an unstable fracture. Modalities. Now we're going to look at some of the modalities we use and when we should not use them. Depending on where you live, this could be an advanced practice, but it's good to know for the OT exam. Something right off the bat, be cognizant of the patient's cognitive status. If there is dementia or psych issues, such as schizophrenia, this is something that needs to be part of your clinical decision-making. We're going to talk about the following modalities. Let's start with moist heat. Moist heat. This increases blood flow. That's why conventional wisdom has told us that right after an acute strain or muscle overexertion, follow the RICE acronym. Rest, ice, compress, and elevate. So that's why it's common practice to ice the spot of an acute injury for 48 to 72 hours to limit the swelling. After this window, apply heat, because that's where we want blood flow and nutrients to the area and the removal of wastes. Now, I know there is some controversy surrounding the RICE technique and what evidence do we have, so I'm not going to delve into that. The take-home message here is that if the patient has active cancer, tumor, lymphedema, or large wounds, stay away from moist heat. We don't want to promote excessive active blood flow to that area. Let's chat about ultrasound. I'm talking about ultrasound therapy, which involves deep penetrating heat and vibration. It drives sound waves into the tissue. So avoid therapeutic ultrasound over the eyes, over the reproductive organs, over pacemakers, or any metal or plastic implants in the body. Even if you think about fractures and bones that are fusing or healing, avoid ultrasound directly on top of this region. And avoid it directly on compromised skin integrity regions, a malignancy, or something you don't want to dislodge, like a DVT. TENS. For TENS, avoid the neck area, not on top of any cancer or malignancy, compromised skin, metal or plastic implants on the body. Also avoid this on the local site of a pregnancy, wounds, and obviously not on top of the heart. Cryotherapy. As the result could be frostbite or worse, you want close monitoring and supervision with this condition, and a good cognitive status. Some of the contraindications include Raynaud's phenomenon, as this can lead to arterial spasming, leading to possible ischemic necrosis, patients with impaired circulation or sensation, PVD, open wounds, and local infection. Also, angina pectoris or other severe cardiac diseases, and we don't want to use cryotherapy near the eye cavity. Use it cautiously over some rheumatoid conditions, and only if the patient's sensation and cognition are intact. Cardiac precautions. Now, let's look at cardiac precautions. If you participate in a cardiac rehab program, there's evidence to suggest you're less likely to be rehospitalized. The patient has to start slowly and progress in intensifying during the cardiac rehab program. Cardiac programs have a graded approach which correspond to the natural process of recovery. Close monitoring is also required. Cardiac rehab is more than just exercise. It's a collaborative approach to care, often involving medication compliance and dietary measures. OTs are involved in lifestyle modification, energy conservation, and providing education about techniques, and a graded exercise program. Also, you should be finding out from the patient and the family, what are the patient's goals and barriers for returning home? Some considerations during cardiac rehab. Patients should avoid holding their breath. Alternate between upper and lower body exercises so you don't overtax muscle groups. In the past, it was thought that isometric exercises, like weightlifting, should not be done by anyone with a heart condition. I was reading the Harvard Health Letter, issued by Harvard Health Publishing, and I learned that there is evidence to suggest that moderate strength training is safe, even in most people with heart disease. So now we know. Let's look at the different stages of rehab together. Acute phase, or phase 1. Here, there is rigorous monitoring of vitals, including blood pressure and heart rate. The patient is hooked up to electrodes. Just a reminder, you need clearance from the medical team before engaging in rehab. There has to be a degree of stability before you work with them. As soon as you see unstable or uncontrolled, your antennas should be up. This means unstable angina, uncontrolled arrhythmia, tachycardia, or uncontrolled diabetes. The corresponding MET level. Wait, let's pause for a second. I don't mean METs as in cancer metastasis, but rather physical activity which is measured in metabolic equivalents, which are multiples of the resting heart rate of oxygen consumption. The formula for how a MET is calculated is listed here on the slide. So, the corresponding MET level here would involve basic ADL activities, such as transfers, feeding, grooming, and slow walking. This means expending 1 to 2 METs. Something to remember is that seated activities, like seated yoga or stretching, put the least amount of strain on the cardiovascular system. So these activities would be appropriate for patients with low activity tolerance. Start with educating the patient and family about signs and symptoms for energy conservation, decreasing anxiety surrounding this acute episode, and ensure they have awareness of cardiac risk factors. Assess and enable the patient's ADLs, transfers, feeding, grooming, activity analysis to ensure work simplification. The goal is early immobilization and to prevent loss of function. The patient is typically seen at the subacute or outpatient level and can participate in OT about 3 days a week here in Phase 2. You are building activity tolerance for a safe discharge home. You still have to provide intense monitoring and patient supervision as they progress through exercises and activity tolerance. If the patient can tolerate 4 to 5 MET exercise for 6 minutes, they can safely do low-intensity activities like light housework. This is assuming they have the insight and rest sufficiently between each activity. Light to moderate housework is about 2 to 4 minutes. So the last phase here is community exercise. The goal of this phase is community reintegration and maximizing independence. Continue exercises to improve physical ability, endurance, and strength. Work hardening also occurs here. Normal working and living activities, excluding recreational activities, rarely exceeds 6 METs. So let's switch gears and talk about autonomic dysreflexia. A quick reminder, heart rate is adaptive. It changes based on external and internal events. So with autonomic dysreflexia, also known as hyperreflexia, the patient's heart rate increases due to a physical stressor. Think hyperreflex. Now this can happen due to a physical stressor like a blocked catheter, skin lesions, severe temperature changes, or pressure stockings which are too tight. This is unique to spinal cord injury patients. This is an uncontrolled sympathetic response elicited by stimuli below the level of injury, meaning that these communication pathways have been affected. The patient will often report a sudden onset headache, and there will be sweating. The OT implication here is to place the client in an upright position to restore blood pressure by removing the stimulus if possible. Do not lie the patient down. It helps if the patient is educated about the signs and symptoms associated with autonomic dysreflexia, that they are aware about the benefits of a bowel routine and the importance of skincare. Buerger's disease. I actually had the opportunity to work with someone who has this condition. Her name was Mary. She was on my caseload to get a new power chair and had both of her legs amputated, one above the knee and one below the knee. She also had her fingertips amputated on both sides. But you know what? She was active in the community, she went to concerts, and sold her art at local art festivals. So what is this condition? It commonly affects veins and arteries of extremities, resulting in thrombosis or clotting. As a result, amputations are common as these veins and arteries get occluded. When you see this, think distal extremity ischemia and peripheral vascular disease. Heavy smoking increases your risk factor for this condition. Due to this PVD, they have decreased ability to detect temperature changes. So what's the OT role? Because of distal extremity ischemia, they have a decreased ability for temperature sensation and often feel cold. For this patient, Mary, I'd seen her in the community. It was included in our care plan for staff members to check the temperature of the water during showering. And because it's just a little cold in Canada, we had to ensure that she had warm clothes when going off-site. Her room was also fitted to have anti-scalding pipe covers in the bathroom. So let's talk about auras and seizures. So to start, what's an aura? In simple terms, it's a warning sign for a seizure. I've had patients describe it to me as a funny feeling, and they knew that at some point during the day they would get a seizure. It can be described as visual, like flashing lights or hallucinations, auditory, or a sensory disturbance, like pins and needles. difficulty producing speech, and an odd proprioceptive sensation. For example, part of your body feels larger than it is. So what's the cause for concern as it relates to seizures, and when should you be on alert? A medical emergency would consist of the active part of the tonic-clonic seizure, also called the convulsive or grand mal seizure, lasts 5 minutes or longer. A person goes into a second seizure without recovering consciousness from the first one, or if a person is having repeated seizures for 30 minutes or longer. What's the OT role in all of this? The OT role is medication management, environmental assessment, and access to emergency services, like having a life alert button. If you're there in the heat of it, like the patient is having a seizure, you want to place the patient down in a neutral or side-lying position and be cognizant of the length of the seizure. On this slide, we're going to go over corresponding precautions to prevent undue stress and to reduce the risk of hip dislocation. Traditional hip replacement surgery involves making an incision on the side of the hip, a lateral approach, or the back of the hip, a posterior approach. The major stabilizers of the hip joint are the muscles and tendons on the back of the hip and on the side of the hip. For the posterior approach, which is the most common approach, the precautions include 1. Do not bend at the hip past 90 degrees. 2. Do not cross your legs. 3. Do not twist. In other words, always have your feet facing forward. For the anterior approach, the precautions look a little different because this approach is minimally invasive. With the anterior approach, which is less common, do not extend past neutral. In other words, no hip extension. So functionally, that would mean do not step backwards with the surgical leg. No external rotation on the lower extremity on the surgical side. No bridging. After the anterior approach, most surgeons recommend sleeping on your surgical side when side-lying. You also see on the slide here to avoid sleeping prone. This is because it's hard to get out of a prone position without doing a prone press-up, which is coming on your elbows and extending your trunk. Regardless of the approach, I always tell my patients to be a penguin when they turn. So what's the OT role, and what are the OT implications for patients who have had a total hip replacement? As always, OTs are part of early mobilization and assessment. We want to prevent loss of function and deconditioning. Often, OTs are involved in assessing for adaptive equipment, like a long-handle reacher, dressing stick, shoehorn, socket, etc., to keep patients functional. Using activity analysis techniques, we want to do environmental assessments, ensure they are not breaking hip precautions during ADLs or personal tasks. Sternal precautions. These are pretty simple. No elbows above the shoulder, in other words, no lifting your arms above your head. No rigorous pushing or pulling. Do not lift or carry more than 5 pounds. What are the implications for OTs? Use a walker for balance only. When resting or chilling out, it is a good idea to hug a pillow. Use this as well for transfers to ensure that you use your big movers in your lower body, your leg muscles for transfers rather than your upper body. There should be no upper body weight bearing until cleared by the medical team. This may require adaptive equipment to make it easier to transfer, like a raised toilet seat, just to make it easier to get on and off the toilet. Mental health. Let's switch gears and talk about cautions and precautions associated with mental health. There will be another video which explores mental health in detail. This is just mental health as it fits into the topic of cautions and precautions. I had to look up some of the legal stuff about what this was in the States because in Canada we have our own Mental Health Act and policies. In the USA, be familiar with involuntary admission. So involuntary admission is used as a measure of last resort. Here, patients are at risk for harming themselves or others. Our professor in OT school told us, for example, if a patient reports thoughts of suicide, do a quick screen for risk by asking if they have a plan. This may be suggestive of involuntary admission. For involuntary admission, the constellation of patients seen typically include an untreated depression, mania, or psychosis. The specific factors seen involve mental illness diagnoses, typically, although this varies between states, dangerous behavior, and a grave disability, as evidenced by the inability to care for themselves and a need for treatment. Legal definitions and requirements vary from state to state, as does the mandatory length of involuntary admission. Involuntary admission is often court-ordered. In the legal and ethical landscape, adults are presumed to be competent. Competency is not a light switch. It's not like you either have it or you don't. Rather, it's specific to certain domains like healthcare, place of residence, finances, participation in social, educational, or employment activities. As healthcare providers, especially OTs, we seek the least restrictive alternative. We are strengths-based. This relates to individual and group therapy, which I will delve into in a future video. After the initial psychotic episode, the patient journey can be broken down into 3 stages: prodromal, acute phase, and recovery phase. In the first phase, or the prodromal phase, this occurs when the individual experiences changes in feelings, thought, perceptions, and behavior. In this prodromal phase, they have not yet started experiencing clear psychotic symptoms such as hallucinations, delusions, or thought disorder, meaning they are not floridly psychotic. What's interesting is that the prodromal symptoms vary from person to person, and some people may not experience a prodrome. In the second phase, or the acute phase, this is where we see typical psychotic symptoms. We would start to see the emergence of positive and negative symptoms. A simple way to think about positive and negative symptoms is positive symptoms. These are symptoms which should not be there, but they are there. This includes thought disorder, delusions, hallucinations, flight of ideas, word salad. What about negative symptoms? This is something that should be there, but is not. So think flat or blunted affect, avolition, alogia, apathy, poverty of speech, amotivation. This acute phase continues until active treatment is initiated. Let's say you're doing treatment. One of the contraindications is to avoid physical contact when they're experiencing active hallucinations or delusions, which are positive symptoms. Recovery phase. This is where the medication gets titrated and the symptoms get less intense or disappear. Medications and psychological therapies are employed, including group therapy or individual therapy. A supportive and collaborative approach to the person and their family is required. What are the OT implications? Let's quickly talk about MAOIs, also known as monoamine oxidase inhibitors. These are used in the treatment of depression and mental health diagnoses. Here are some examples listed on the slide. What are the treatment implications? There are some considerations for patients receiving these medications. Dietary restrictions. Tyramine, dopamine, and tryptophan. These are typically found in dairy, meats, and caffeinated beverages. OTs should be cognizant of this contraindication and determine if a dietitian consult should be indicated for a long-term solution. In the short term, OTs need to be aware that a combination of MAOIs in tyramine, dopamine, and tryptophan can lead to an increase in blood pressure, significantly increasing the risk for a CVA. A symptom of this would be a headache and/or profuse swelling, so if this is observed, notify the physician or medical team right away. So the OT implications here include what we just talked about. Dietary restrictions, being aware of the contraindications for eating foods which contain tyramine, dopamine, and tryptophan. You should also be aware of the side effect, photosensitivity. This means if you're doing a group outside, be aware that patients should be dressed appropriately. Could be something as simple as wearing sunglasses and a hat to protect themselves. so stay away from the strobe light parties. Something that you see here on the slide that I didn't mention is the serotonin syndrome. I want to take a moment to chat about this now. Serotonin is a neurotransmitter which resides in the brain and is involved with chemical messaging. Quite often, antidepressants such as SSRIs or even pain meds like tramadol, the over-the-counter cough suppressant, can increase the level of serotonin. If there is too much serotonin built up in the brain, this is called the serotonin syndrome. Symptoms include dilated pupils, nausea, tremors, GI symptoms like diarrhea. Although it's rare, it is severe. It can lead to an increase in blood pressure and can increase the risk of a stroke. So if you observe this, report it to the physician or medical team right away. Now let's look at the third category, or miscellaneous cautions and precautions. If there's child abuse, you have the professional obligation to report it. Something worth mentioning, for seniors abuse, you have to follow site policy for reporting abuse. You want to be cognizant of the patient's cognitive status. Is the decision-making ability in question? Any indications of delirium or dementia? Dementia and sexual activity. This is something you hear about more, and the ethical issues surrounding this topic. Just remember, consent is required each time, and it falls under the site-specific policy. Hey everyone, thank you for studying with me today. You can check out my website to download my handouts free of charge. Don't forget to like, subscribe, and follow me on Instagram and YouTube, and I'll catch you in the next video.